Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go take a look at reallifepharmacology.com. We've got a free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher. I threw a lot of things on there that are actually happening in real-life practice, as well as those things that frequently show up on pharmacology exams and board exams throughout your career. So that 31-page PDF, absolutely free to use, simply an email. We'll get you access to that, and we'll get you updates when we've got other content available as well. So go check that out at reallifepharmacology.com. All right, getting into the medication of the day today. This drug is Cefepime. This is a fourth-generation cephalosporin. You could also classify it as a beta-lactam type antibiotic. Mechanistically, this medication, like many other cephalosporin antibiotics, inhibits bacterial cell wall synthesis by binding to penicillin-binding proteins. Now, what's interesting about Cefepime and why it's, considered a further down the line generation cephalosporin, is it tends to be more resistant to beta-lactamases compared to some of the earlier generations. So, comparing it to a medication like ceftriaxone, which is frequently utilized in a hospital type setting, Cefepime helps avoid being broken down better by beta-lactamases that are produced by bacteria, so they can help us potentially treat infections that maybe are resistant to some of those earlier generation cephalosporins. Talking about coverage for Cefepime, it is a broad-spectrum antibiotic and can cover many gram-positive as well as gram-negative bacteria. It's important to note that Cefepime does not cover MRSA like many of the other cephalosporins. So methicillin-resistant Staph aureus, you should not be using Cefepime to treat this infection. However, Pseudomonas, a commonly resistant bacterial infection, is covered by Cefepime, and there's maybe actually some evidence to say that it's even less resistant than ceftazidime. So ceftazidime is a cephalosporin that can commonly be used for Pseudomonas, and Cefepime maybe even shows that it's even less resistant in some cases, or can potentially treat infections that are resistant to ceftazidime by Pseudomonas. Okay, so definitely a good note there to remember. It does cover Pseudomonas. Cefepime does not cover MRSA. Indications, because of the pharmacokinetics, it has penetration to a lot of different tissues in the pharmacodynamics. Pneumonias, complicated UTIs, intra-abdominal infections, skin and soft tissue infections. So there's lots of different uses that we can utilize Cefepime. Dosage forms, IV, IM. This is not an oral medication, so going to be used typically institutionally more so than outpatient. The dosing of this medication is anywhere from 1 to 2 grams every 8 to 12 hours. You may see rare cases where it's given every 6, but that's kind of the usual ballpark, 1 to 2 grams every 8 to 12 hours. With that said, renal adjustments are required. So pay attention to that. Monitor renal function, very, very important. And we may need to lower the dose and or reduce the frequency depending upon where that creatinine clearance, where that GFR falls. All right, adverse effect profile, as you could expect with most antibiotics, you can certainly cause some stomach upset, some nausea, some diarrhea, vomiting. Again, similar to other antibiotics, rash, itching, skin type reactions certainly can happen. You can get some, generalized aches and headaches and things like that as well. Serious type of reactions. So one of the things that comes up with cefepime is risk for neurotoxicity and an increased risk for seizures. Typically in your standard patient that's otherwise healthy and we're just treating an infection. Younger patients, probably not terribly common. That risk tends to go up as we have patients with poor renal function, as well as potentially elderly patients as well. They're more likely to probably get some of that accumulation. Maybe the dose is inappropriately high as well for them. So that's definitely something to look out for, particularly in our more sensitive populations where we've got renal impairment and or older age. Other rare things you may see, hypersensitivity reactions, so those skin reactions that can progress to something more serious like Stevens-Johnson syndrome or even anaphylaxis type situations. C. diff associated diarrhea, colitis, that risk can certainly be increased as we use this antibiotic. Rarely bone marrow suppression you may see, neutropenia, thrombocytopenia, those type of things. Nephrotoxicity, not incredibly common, another rare thing, and probably more unlikely to happen when we use other medications with that, and I'll cover that in the drug interactions section. One thing to pay attention to is allergy to cephalosporin antibiotics, penicillin antibiotics. There can be some cross-reactivity. Really, really important you get that background history. Okay, so whenever somebody reports that they had an allergy to a cephalosporin antibiotic, for example, we want to know that history. Many times it's not severe, not a big deal. Let's say nausea or stomach upset. So really, really important to get that history. Now, if they had life-threatening anaphylaxis, couldn't breathe, that type of thing, there's a situation where we're probably going to do a deeper dive and look at some of the other antibiotic options that we might have in that type of situation and potentially try to avoid the use. So again, looking at that, understanding the previous reaction, what medication caused it, and the severity of that reaction is really, really important. A couple other things, pay attention if you see a patient that is on medications for seizure disorder. That may be, a little bit more cause for concern. May want to be a little bit more cautious about paying attention to the dose and what dose we're using and those type of things as well. Last, before we get to drug interactions, I want to touch on kinetics and monitoring a little bit. So I alluded to that renal function. We want to make sure to pay attention to that. Other things, particularly in the elderly, you'll probably pay attention to neurological status, keeping tabs, making sure that that seizure risk isn't happening or we're able to catch it quickly. And then, of course, clinical response to the infection. Making sure that the patient is actually improving if we're using this medication. Rarely you may see, CBC and liver function assessed. This is probably more so with prolonged use. So just take that for what it's worth there. And then, kinetics-wise, it's got a relatively short half-life in the range of a couple of hours. So as you could expect, in patients with normal renal function, we need to dose this at least a couple times a day. So, and maybe up to 3 times a day, kind of depending upon what we're trying to do, what we're trying to treat, and how aggressive we need to be. The elimination of this medication is primarily renal, which you could expect because I've been talking about making dose adjustments based upon renal function. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like ambulatory care, BCPS, NAPLEX, geriatrics, or BCMTMS, go check out meded101.com/store. We've helped thousands of pharmacists prepare and pass their board exam, and we can absolutely help you too. So go check that out, support the sponsor, meded101.com/store. All right, wrapping up with drug interactions, there isn't a ton, and that's true, I would say, of most penicillin and cephalosporin type antibiotics. Keep tabs on renal function, that nephrotoxicity risk, aminoglycosides, vancomycin, loop diuretics. If we're on other medications that potentially could have that additive effect, we're probably going to want to closely monitor that renal function and make sure that we're not inducing an acute renal failure and nephrotoxicity. Now, again, using Cefepime, it's probably a hospitalized patient already in many situations, or they're closely monitored in an outpatient setting, maybe getting this medication through home health or something to that effect. But yeah, monitoring and paying attention to that renal function is going to be important, particularly in relation to a patient taking those other medications as well. Warfarin, possible for increased anticoagulant effect. We're likely just going to monitor INR, which is probably easy to do in the setting that this patient's likely to be in. Seizure meds, pay attention. We could have that opposing type effect, that increased risk for neurotoxicity with regards to those medications. And then last, I'll mention there are a couple of vaccines, cholera and typhoid, that may have their efficacy interfered with by the use of Cefepime. Again, probably not something you're likely to administer in a patient that's sick and not doing that great and needing Cefepime, but I did want to mention it for completeness' sake. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, share us with friends, colleagues, leave us a rating and review. Those things have all helped this podcast grow into literally millions of downloads, and I'm incredibly thankful for that and your willingness to share and support this podcast. Of course, support the sponsor, meded101.com/store. Your purchases there go directly to support this podcast, so I greatly appreciate that. And of course, if you want to reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care, and I hope you have a great rest of your day.